for having me here. I'm going to try to focus attention on the issue of integrating mental health care into primary care geriatrics, a field where I feel that I spend most of my time. Let me set the stage a little bit. I think we know at least three things or more about aging and mental health. One is somewhere between 18 and 30% of older people have some form of diagnosable mental health problem. Second, we know that older people respond to treatment, whether it's biological treatment, such as through the use of medicines, or through psychological treatment or social treatment through psychotherapy or group programs. And a third thing we know is that older people don't always get the treatment that they need. Very few, in fact, get appropriate treatment in the community. Estimates range from anywhere from 25% to 70% being undertreated, mistreated, or not treated. And so I thought I'd focus some attention on the integration of mental health care into primary care geriatrics, because another thing we know about older people is they certainly go to the doctor. Let me start from there. Is the slide projector on? I think that there are three roles that mental health specialists play in geriatrics. I think in my clinical time, I think these are some of the roles that I play. One is to help detect, assess, and treat mental health problems. That should be a role. Second of all, and a question I get asked a lot, is determine the influence of psychological versus physical determinants on health status. I get many requests from my physician friends of how much of this person's problem is psychological and how much of it is physical. It's almost a spin on the old idea that it's as important to know what kind of person has an illness as what illness the person has, so that we can approach them with the proper kind of care. And the third thing is to advise the treatment team on approaches to care for this person based upon their mental health needs and their psychological status, not all of which are mental health problems. For example, this person's own values and interests, or their motivations, or their own personality, which aren't necessarily mental health problems. As we try to improve mental health services for older people in the context of health care, we run into two major problems. One is detecting mental health problems that older people have. A second is the fragmentation of service delivery to older people. Both of these are major problems and may stem from still a third challenge, and that is the complexity of assessing and treating mental health problems in older people who have coexisting physical health problems. One model of mental health that I think is especially valuable for older people is to think of it in terms of a biopsychosocial model. Many of you are familiar with biopsychosocial model, where in the middle of these three circles you have function. That is the person's daily living skills and how they're able to function in the community. But you can easily change the diagram around and put mental health in the middle and realize that mental health, especially in most older people, is a combination of biological, functional, and social factors working together to create mental health problems. The problem that we have as clinicians is to determine what factors are present contributing to the mental health problem. How do you assess each of these? For example, how much of this person's mental health problems is because they are hypothyroid or on the wrong dose of a medicine? How many of the problems the person has are a result of low self-esteem secondary to not being able to toilet themselves, which is a functional problem? How many of their problems are due to they live in poverty and don't have access to community resources? And how much of it is a primary mental health problem? as you work more and more with older people, their mental health problems become more involved and integrated in these kinds of issues and problems. So given the complexity of mental health problems in older people, our task, this produces, in a way, the problems with detection and produces the problems in treatment and assessment that ends up with our fragmentation. Let me give an example of using depression as how it changes depending upon the nature of the person's medical state, medical problems, social and functional status. These are data taken out of Baron Sloan's Handbook on Aging and Mental Health, and part of these are from the epidemiological catchment area studies. And some people are still surprised by these data that show that older people living in the community, if they're not medically ill, have lower rates of diagnosable major depression than do younger people. And it makes intuitive sense. If you're living in the community, you're well, you have decent income, something to do, a relationship with somebody, life is pretty good. But if you add medical illness to this complication, especially in this case acute medical illness, you see that the rates of older people then go up and surpass the rates of younger people. If we talk about not major depression, but depressive symptoms that are bad enough to interfere with functioning, then we see that the rates are higher in older people slightly, and if you add medical illness, they even go up even further. Some of my research interests are in the problems of the mental health problems that people have chronic disabling illness. And chronic illness is the most common and most important set of physical illnesses among the older population. So here's a study we did recently on using the geriatric depression scale and looking at rates of depression in people with various kinds of chronic illnesses. And on the left-hand side, you see our non-disabled population. The yellow indications are a medium-high amount of score on the geriatric depression scale, and the red are high scores. And these data on the left correspond to roughly the epidemiological catchment area studies and studies by Blazer and Williams and others. And we have a particular interest in another phenomenon about aging and disability, and that is we're looking at people also who acquired a disability early in life and now, for the first time in history, are aging with it. Usually you think about the late onset of illnesses, but there are approximately 7 million people in the country who had the early onset of a chronic illness who now are aging. And one group of these people are people with post-polio. And you can see that they are slightly higher than the non-disabled population in terms of depressive symptoms and depressive diagnoses. And as you go over to stroke, when you add those two columns together, the yellow and the red, you're up a little higher than 50% have a diagnosable depressive disorder that's bad enough to interfere with their functioning. And partly because spinal cord injury is getting attention also these days with the devastating injury to a movie star, we have data on people aging with spinal cord injury. That is, what will this person look like 30 years out? And we find that 42% of people with a spinal cord injury earlier in life, 25 plus years, have a diagnosable depressive disorder. So if you take the complexity of mental health in the older person, it shows that I believe these data show that adding functional difficulties, medical problems, social problems together really typifies what the older person is more like than the older person living in the community has something to do and doesn't have as many mental health problems. Also, there's another phenomenon that appears in geriatrics, I think, affecting mental health, physical health, and functioning, and that is mental health symptoms seem to have a bigger effect on functioning in an older person than they do in younger people. That is, given the same score, let's say on the geriatric depression scale, it may or may not affect a younger person's ADLs, activities of daily living, but that same level of depression can affect the older person's activities of daily living, which then in turn creates another problem, which creates another problem, which creates another problem. So this integration of biological, psychological, and social factors together, which is really the hallmark of geriatrics as far as I'm concerned, is very important in terms of its mental health perspectives. Right. So one problem we face is complexity. It is the mental health problems of older people typically are very complicated. They have biological problems, they have functional problems, they have social problems, and they have mental health problems. And the task of us clinicians is to try to sort out which of these are contributing to which, try to assess them as best we can, and try to treat them. One of the outfalls of this complexity is that detecting mental health problems among older people becomes difficult. We already know that. We also know that it's difficult because older people don't always report the symptoms of mental health. They don't report them the same way. Clinicians don't take the time always to ask the person thoroughly about symptoms. We know that people can present with mental health problems who have physical health causes. We know that detecting these problems becomes difficult. There's stigmatization of older people. They don't get as much time spent on mental health. And as we move towards managed care more and more in the United States, we're going to have even more of this problem, where the average appointment time for a new patient in managed care may be anywhere from 15 to 30 minutes. And how much of an assessment can you do in 15 to 30 minutes for a patient? So we're going to see more and more of these difficulties as we go along. These are data that we collected in a study several years ago, about 1988. Waldo Lopez-Acuris and Fred Staples and myself looked at depression among older Hispanics living in Los Angeles County. And we were interested in are the problems that people have detected. And we did the study by buying the census data tracts from the government and then doing a sampling base on all of LA County. So these data are based on 1,000 people, roughly, where we went out and did assessments in people's homes. And a couple of things turned out interesting along the mental health line. One is that we divided people into depressed and non-depressed, and we did a very careful review of their questionnaires, their interviews, and by depressed, in this case, we mean that they probably met criteria for major depressive episode. And then we divided them between the depressed and non-depressed. And we see that among the depressed patients in the community, and this number now is over 100, 90% saw a doctor last year. And among the non-depressed, only 78 did. So we know people go to doctors. 25% were taking a psychotropic, and no one was taking an antidepressant. So in this population, there are problems in detection. And you might say, well, but yes, that's a Hispanic population, there are difficulties with language, etc. My response to that is no. If you look at the literature, you find the detection rates of people going to physicians and going to clinics and going elsewhere is not very high for appropriate diagnosis. And yet, this is an area where we need to really focus attention because the primary care physician becomes the mental health professional also for many older people. We also know that from some of our research and from looking at literature and others, that approximately, depending upon what subpopulation you're looking at, anywhere from 25 to 70% of people who go to primary care physicians have some form, older people, I'm just talking about older people, have some form of mental health problem brewing with them. We've operated for close to 20 years a comprehensive evaluation clinic at Rancho Los Amigos Medical Center and have data on over 2,000 patients coming to see us for an evaluation. That group comes to see us because they are maybe more at risk than the average person going to a primary care physician, But what we have found in our data is over 70% have a coexisting mental health problem, even though they're not coming to us for a mental health problem. Primarily, they're coming to us for medical care. And the problems that you see most commonly in the community include depression, cognitive impairment, anxiety disorders, psychotic disturbances, substance abuse, personality disorders, and family issues. And so it's become for us not a question of does this person have a coexisting mental health issue that needs to be addressed, but which one is it, I wonder. And so we find that unless we focus attention on those psychological mental health problems, the rest of the care of the patient falls apart. I saw a patient last week at the request of a family physician I work with, and we couldn't quite figure out what was going on with the woman because she wasn't as functional as she should be given her medical history and her medical problems and her social standing. And she was one of these people that had been using a very old line medicine, Metro Baymate, Milltown, since the 1950s, and didn't tell anybody. And just got a refill by mail out there in the community for all these years, and was taking 2 of these a day, just because she couldn't face life's problems. And it certainly seems to account for some of the dysfunction in her functioning that we saw. Another problem that happens as a result perhaps of the complexity of mental health problems in life, as well as the way our systems of care are organized, is fragmentation. That is, in order to truly address the mental health problems of older people well, who have coexisting medical and chronic illness problems, you need to somehow bring together attention to those biological problems, those mental health problems, the functional problems, the social problems. How do you do that? What models work? What models have been tried? What seems to help? It certainly is a problem. There seem to be 2 general approaches people take, and they seem to occur in maybe at least 2 different broad settings. One is multidisciplinary and one is interdisciplinary. Multidisciplinary care refers to having services available from multiple disciplines that are available to the person, the patient, at least sequentially. That is the hallmark of multidisciplinary, or multiple services, but not necessarily all integrated together in time. So that in the community you can have multidisciplinary care. If you had a patient who went to the primary care physician, and the physician recognized that I think there's a problem here and I need to refer you over to our OT, and sends the patient to the OT, who maybe says, well, maybe there's a problem here psychologically too, who can then refer the patient to a social worker or a psychologist or psychiatrist who thinks maybe we have a social problem too, and refers the patient back to the social worker. That's multidisciplinary. Multiple disciplines are available and they can be referred to. But it also tends to be sequential. And there's not necessarily integration between the team members in terms of communication. And multidisciplinary can also be slow. It might take 6 weeks to 2 months to make all those referrals around. Interdisciplinary refers to a team, a multidisciplinary team who works together around the same patients and around the same time frame. So that an interdisciplinary team would have a physician and a social worker and a physical therapist, an occupational therapist, and a pharmacist and others available to discuss that patient and talk to each other about the patient. Programs that are either multidisciplinary or interdisciplinary seem to provide pretty good care in the community. And they can also be arranged to provide it through primary care systems. And I'll talk about a couple of examples. Would it be possible to get just a tad more light up front here? Thanks. Bob Knight and Brian Koski reviewed the literature on community-based multidisciplinary programs in the community for publication by the American Psychological Association. And they found 4 or 5 characteristics of successful programs in the community that address mental health problems of older people. One is there's a strong emphasis on detecting mental health problems. You know, the old rubric that 75% of good care is a good assessment to start with is probably true in geriatrics. It's been my experience that most of the mistakes that are made up front, of not really doing a really good assessment and knowing what all the problems are. And Knight and Koski found that one of the characteristics of good programs that delivered good mental health care was they had strong assessment up front. Another characteristic they found is they delivered some of the services in the homes of people. That is, not everything was required to go to the doctor's office or go to the clinic. The patients were seen at home. Doing a home assessment up front is also very important, if it's possible to get it done at all. For a number of years, for 20 years, we've been operating a program on the last of Johnson's War on Poverty money, if you can still believe it. And that's provided us funds to go out in the community to assess people before they come to see us. And that tells you a great deal about the patient. The nurse practitioner becomes very adept at, well, now show me the medicines you really take. You know, let's go to the bathroom, but more importantly, let's go to the kitchen and look in there, because most people don't keep the medicines in the bathroom. They keep them in the kitchen next to the dishes. Or, you know, let's see how you really do things at home. Because people, as you know, will tell you great things about how they're getting by and say, I have no trouble with this. You know, and so we had one older man who said, I have no trouble getting up from the toilet. Oh, that's good. But if you just stopped there, you'd miss the point. So we said, well, show us how you do it. So he goes and sits down in the toilet, reaches out with his cane, grabs a towel bar, and pulls himself up. See, no problem. Until the screws come out of the wall. Or people who say they're doing fine, and you find out at home, you know, they have empty liquor bottles around and so forth. So not all the services in the office, not all the services in the clinic. A third characteristic of the programs that Knight and Cosby found were good was they had an interdisciplinary team that could talk with each other fairly frequently and openly. Another characteristic of successful mental health programs, and one I'll give another example of in a minute, was active case finding. That is, they actually went out in the community and tried to find the people who needed help. By dealing with social service agencies, by talking even to mail persons delivering the mail, to making people aware of the services to find out who really needed services. Because, you know, it's very easy for those most in need to shut themselves in at home. And finally, they had collaboration with other agencies in the community. So that they had cooperation with area agencies on aging, multi-purpose senior citizen centers. They knew the contacts at Adult Protective Services. They knew how to get Meals on Wheels. They knew how to access SSI. So that the good mental health services provided a way of linking in with the social services as well. I'll give you a couple of examples of studies that are reported in the literature to do that, and then close up with one thing that we're trying to do. In 1987, Barry Lebowitz and Edith Light published an article describing the integration of community mental health centers with AAA centers, area agencies on aging, in the community. And they studied over 250 centers. And they found that the community mental health centers that integrated themselves with area agencies on aging increased the number of services to older people by about 40%. And they got services that older people needed in the community. So it really helped to fill that part of that Venn diagram that deals with social issues. This year there's an article in JAGS about a Canadian study that developed an outreach program from a community psychiatric hospital and did outreach to physicians in their private offices, to long-term care facilities, and to home health agencies. in terms of a case finding and liaison services. And they report very good results with improving services to older people in the community. Let me tell you finally a little bit about one of the things we're doing. As you know, the counties are in great jeopardy in this country. We've operated successfully in LA County for 20 plus years, a major geriatric service that we now may have to privatize in order to keep it going. So we've been experimenting with trying to do interdisciplinary care in a private practice model. And everyone reaches for the beeper. And we have developed an integrated team in Pasadena with a family physician, psychologist, social worker, pharmacist, and therapist. And we're now trying to make this cost-effective in the community and by having patients be seen for comprehensive assessment and linking them to services not only in the office, but linking them to services around the community. And we think that this is a way to try to approach mental health problems in this group. In this private practice model, we are finding that well over 50% have a coexisting mental health problem that, if not addressed, will interfere with their medical care or with their functioning at home. Let me conclude by issuing a challenge then, since it seems to be what I'm supposed to be doing. And my charge to this conference would be to help to improve understanding, training, and implementation about the challenges we have in geriatric mental health, especially in regard to integrating it into primary care geriatrics. We need good understanding of the complexity of these problems, which I think you're going to hear a lot about from the speakers that follow. We need ways to improve detection of these problems and who has them. And we need ways to improve the integrated care of services that people need to resolve these problems and to reduce fragmentation. Thank you very much, and thanks for having me. Any questions?
Well, I'm delighted to be here and talk about several areas of interest, delirium, dementia, and depression. And one might even subtitle this talk, Everything You Wanted to Know About Geriatric Psychiatry But Were Afraid to Ask, because it really is a broad challenge to cover all these areas. What I'm going to try to do is touch upon some issues about diagnosis and assessment, focus on some of the treatments that we have available, and hopefully have some time at the end to entertain any questions that we may have. So if we can bring the lights down a little bit. Here's the first slide. The caption reads, Mr. Bucks, would you share the secret of your long life with us today on your 200th birthday? Well, for those of you who aren't tremendously myopic, you can see that there's really no secret to Mr. Buck's long life. He's hooked up to all these newfangled technological triumphs, and he's being kept alive very long. And the advantage of all this medical technological development is that we're living longer. The disadvantage is that the quality of life is certainly diminished, and we see a tremendous impact on the mental health of our aging population. If we look at figures from the U.S. Census Bureau and estimates into the next century, we can see that for each decade, this is 1950s, 60s, 70s, 80s, and up into the year 2040, The upper part of the histogram represents the old population, 85 plus, and we're looking at estimated numbers of cases of severe dementia by that age over this span of time. And it's clear that this old population is at the greatest risk for dementia, and these are the ones who are developing it. The figures, if you walk into a nursing home facility, several studies suggest that at least 1 out of every 2 nursing home residents has a dementing illness. Now, what do I mean by dementia? I like to think of it in terms of a syndrome, that is a cluster of signs and symptoms. And we'll talk about the various causes of dementia, but just very simply put, there are several components in the definition. One is that there is memory impairment. That's a key feature of dementia. Secondly, you need impairment in at least one other cognitive domain. Often we see language problems or people have trouble searching for the right word. They may make up words. There can be personality changes, thought disorders. There can be what we call constructional difficulties where people will get lost. They have problems with their visual spatial skills. They have trouble dressing themselves. So, and the third component is that there's an impairment in social or occupational functioning or both. So those are the 3 components: memory disorder or memory loss, one other area of cognitive loss, and it impairs with the person's functioning. Now, if someone meets those criteria, there are a lot of different possible causes for it. Here, if we look at a cognitive ability on the vertical axis versus duration of the dementia or the illness on the horizontal axis, and in a typical case of Alzheimer's disease, you see this gradually progressive course. About 60% or so of the dementias of old age are represented by Alzheimer's disease. But about 15 or 20% are caused by small strokes to the brain. And here's a picture you'd see there, the so-called stepwise decline for vascular dementia or multi-infarct dementia. But then we see a lot of patients who have features of both. And you might see a gradual decline in part of the illness, but a sudden decline in some other part. And that can represent a lot of different syndromes. It can be a patient with Alzheimer's disease plus small strokes. It can be someone with Alzheimer's disease who gets some kind of intercurrent physical illness. It can be Alzheimer's disease plus a depression, and we'll talk about some of these different possibilities. So to get into some more of the causes of a dementia syndrome, here we see the differential diagnosis, and one can think in terms of disorders without specific treatments, and the most common one is Alzheimer's type dementia. In previous years, I used to say, well, this is an illness that we have no treatment for, and also we don't know the cause. But that statement is not entirely clear because there have been considerable breakthroughs in our understanding of the genetics of Alzheimer's disease. Now, for a small percentage of patients with Alzheimer's disease, we know that the cause is genetic. And this is in situations where there's a very strong family history of Alzheimer's disease, where practically half of relatives who live to the age at risk develop the illness. Often in these families, the illness begins in what we call a pre-senile age group, before age 60. And in those situations, there have been gene mutations on chromosome 1, chromosome 14, and chromosome 21. But this is relatively rare. More commonly, what we see is a genetic risk that was mentioned a moment ago. That's apolipoprotein E, or ApoE, which is a genetic polymorphism, meaning that this is a gene that comes in 3 forms: 2, 3, and 4. 2 and 3 are the good ones. 4 is the bad one. And you inherit 1 copy from each parent. If you have a double dose of 4, it increases your risk of getting dementia dramatically. If you have a single dose, it increases your risk, but not as much. Now, I mentioned risk rather than cause, because with ApoE, it is not a cause for Alzheimer's disease. It's just a statistical increase in risk, which has implications in terms of what we inform people about the results of the tests. And I see later on you'll be talking about some of those issues in the conference. Other disorders without specific treatments, multi-infarct dementia we mentioned, PICS, Huntington's disease, and then there are psychiatric disorders that I'll focus on, particularly depression, the overlap of cognitive dysfunction and depression, paranoid disorders. Many times patients with Alzheimer's disease become paranoid, and one way of understanding the situation is that the paranoid stance is a way for filling in missing information. And it's probably something we've all done at one time or another, where we might misplace our keys and then say, well, who took my keys? And then you find them and you feel kind of ridiculous. But you can imagine someone who has a predisposing personality of suspiciousness becoming demented. They're missing a lot of information. They become outwardly paranoid. Sometimes patients with mood swings, bipolar disorder, mania, and depression can look like they have Alzheimer's disease also. And a lot of people have age-associated memory impairment, mild memory complaints that usually does not progress. And some of our research is aimed at trying to understand these mild common memory complaints and when they will progress to more serious memory disorders. There are a lot of different medical conditions that can cause these problems, and here you see some of them listed. Drug effects are especially important in elderly people because of the medical conditions and subsequent polypharmacy. Intracranial conditions, cardiovascular disease, vitamin B12, folic acid deficiency, and so forth. Now, delirium is another clinical syndrome to recognize. Delirium can occur while someone is demented. It can occur while someone is depressed, or it can occur on its own. It's important to recognize because the outcome of delirium can be quite serious. The mortality rate can be quite high depending on the underlying cause. And so it's something to aggressively look for and to try to treat in terms of its underlying cause. The diagnostic criteria include the following features: disturbance of consciousness, that is, people have trouble focusing, sustaining attention, and they tend to shift attention. So a typical situation is you'll walk into the room and you'll be talking to the patient and they'll fall asleep. Or else they'll hear the helicopter and they'll be distracted. Another feature, cognitive change or perceptual disturbance. So certainly the cognitive change is shared with one of the features of dementia. You see a rapid onset in hours to days, and there's a fluctuation in the course, and generally there's an underlying physiological cause that's identified, though some studies suggest that in 20% of cases a cause is not found. Predisposing factors include medical illness. 15% of inpatients in several surveys have a delirium, underlying dementia, age, and drugs, particularly anticholinergic drugs and CNS depressants, which many of our older patients are taking. Well, depression has hit the cover of the national news magazine, so we know that it's an important problem at any age, and you hear figures of a 15% lifetime risk for developing depression. And in older people, the more serious depressions, I think, have been underestimated in part because they're hard to recognize. If we look at data from a large national survey from the 1980s, the Epidemiological Catchment Area Program sponsored by the National Institutes of Health, and this gives us prevalence of depression according to sex and women versus men. You can see that women are more likely to get depressed than men at any age. Now, my wife tells me it's the men making the women depressed. But there are other explanations. People have considered hormonal differences. There are certainly family studies that interestingly show that in some families you see depression in the women, but alcoholism and antisocial personality in the men. And this is definitely a recognized phenomenon. Another very interesting feature of this study, you find that when you reach the 60-plus age group, notice that the rate of depression drops off for both men and women. And again, I think that there's lower recognition that results in that, and we'll talk about some of the difficulties in diagnosis, and also the increase in dementing illness. I think a lot of these depressions are masked, in a sense, by dementias. So just to review a few bullets on the epidemiology of depression in late life, major depression, which we'll define in a moment, has been found in 1% of community-dwelling elders, 15 to 25% of nursing home residents, 13% annual incidence of new episodes in nursing homes is certainly something to look at in our long-term care facilities. 5% prevalence of major or minor depression, which, as the name implies, a less severe form, in elderly patients in primary care clinics. 8 to 15% prevalence of subsyndroma, or these minor depressions, in community samples. Now, what I mean by depression is, again, a clinical syndrome where you have the following 8 features. And this is a simple mnemonic that helps me remember it because of my age-associated memory impairment. And the mnemonic is SIG, E, CAPS. So SIG is what we write on our prescription pads, and this is when to prescribe the energy capsules. So people who get depressed have trouble sleeping through the night. They have loss of interest in their usual activities. They have feelings of guilt, low energy levels, concentration impairment, loss of appetite, what we call a psychomotor disturbance, wherein the patient is slowed down in their general body movements or thoughts, or else they're speeded up. They might be wringing their hands or pacing. And then finally, there are often thoughts of suicide. Now, let me just make 2 points about suicide and aging. First, age is a risk factor for completed suicide. Particularly Caucasian men are at increased risk for suicide. So anytime you hear an elderly person talking about suicide, you need to take it seriously. I often tell our trainees, hospitalize now, ask questions later. Although in today's day of reducing length of stay, we're probably a little more conservative with that. The second point is that many elderly people feel that suicide is taboo. If you ask them, would you kill yourself, they'll say, oh no, I would never do that. That's against my religion. But if you ask, would you feel better off dead, they'll say yes. And if they say that, that counts as one of these features. If somebody has 4 or 5 of these features, and it's been going on several weeks, then we make a diagnosis of major depression. Now that's important because clinical trials comparing antidepressant drugs or psychotherapy with placebo find that people with this clinical syndrome get better. In young adult populations, it's up to 70% on the first drug. In older adults, it's a bit lower, maybe around 60%. Now, with older people, in addition to some of the differences about suicidal thinking, we see a real emphasis on failing memory, and there are several clinical syndromes to consider. One is what used to be called pseudo-dementia. People don't like the pseudo term, and so they've changed it to dementia syndrome of depression. Essentially, this is where someone sort of looks like they have Alzheimer's disease, but really it's a reversible depression. You treat them with an antidepressant, and they get better. Some studies suggest that if there's an acute onset of the depression and a rapid progression, an acute onset of the symptoms and rapid progression, or if there's a prior history of depressive episodes, that diagnosis is more likely than an Alzheimer-type dementia. Another clinical syndrome we see is a brain disorder causing a mood disorder, and a typical example would be a post-stroke depression, where some groups have found that strokes, particularly in the left frontal regions, are likely to cause depression, and these depressions, too, will respond to antidepressant treatment. Finally, there's often a psychological reaction to the cognitive deficits, and we see this very often in our patients with progressive dementias, particularly early on, when they're aware of the deficits, and they can develop a secondary depression. Another area where diagnosis becomes difficult is with somatic complaints. Many older people, when they get depressed, they focus on their physical complaints, and they might not actually feel sad or blue, but it's the back pain and the constipation and so forth. And they have these so-called masked depressions that will respond to antidepressant treatment. This situation is further complicated by the fact that older people are likely to have chronic physical illnesses. And these illnesses are likely to be associated with depressive illness. Some studies suggest that up to 50% of patients with significant physical illness get depressed. Nearly 50% of older people have arthritis. We see hypertension in 40%, and let me add that drugs to treat hypertension can cause depression. And so it's something to be aware of, and we know that a lot of these physical illnesses will cause symptoms in and of themselves that look like depressive symptoms. If you look at the onset, the age at onset when a person first gets depressed, you find some interesting features. And if we divide people up according to if they got depressed for the first time in early life versus in later life, you find that people with late onset depressions have a lower frequency of a family history of depression, and they have a higher frequency of comorbidity. They're more likely to have cognitive impairment, cerebral atrophy. They have white matter disease. If you look at an MRI scan, they're more likely to relapse. So this may be a different kind of depression in late life when it occurs for the first time. Both forms are treatable. We treat illness here, Ms. Rothbart. If you insist on being cured, you'll have to go to some quack. I guess these cartoons, everybody's seen these cartoons, and they're not funny anymore, so I'll delete this one from the next talk. It's not the prognosis is not as bleak as that cartoon suggests. Let me just, before we get into assessment and treatment, review a few of the complicating factors in assessment and also mention a few others I didn't. There's overlap of symptoms. We talked about the overlap with memory loss. Certainly agitation you can see in depression, you can see it in delirium, and you can see it in dementia, all three. Insomnia can be perplexing because we know that as we get older we need less sleep. And often you see an older person comes in and they say, well, doc, I can't sleep, I've got terrible insomnia. And so the doctor may be inclined to start them on a medication, a benzodiazepine or some other sedative. If instead the physician were to take a careful sleep history, that physician may learn the following. It may learn that the patient, well, goes to sleep at 9 o'clock at night, has no trouble falling asleep, does terrific. But every night at about 2:30 in the morning that person gets up and can't fall back to sleep. Well, if you add up the hours, you find that that person is really perhaps getting enough sleep for that age group. And the problem is not in insomnia, but really in shifting the phase of sleep. And that kind of careful history can avoid some of the overuse of medications that we see in many of our older patients. There's a medical comorbidity, the psychological reactions to these illnesses, as well as the physical symptoms that we see. So people with, say, congestive heart failure may develop fatigue, which could be confused for depression. The somatic equivalence of the mass depression and the emphasis on the cognitive complaints. Now, a few points about assessment. It's very important to involve caregivers and relatives from the beginning. This is particularly true if an older patient has cognitive impairment. You're just not going to be able to get an adequate history. Often what I will do when the family comes in, and I inform them, I say, I'm going to spend time with each of you alone and then together. That way I can get accurate information. I don't have the situation where I'm taking a history from one family member and the other family member is signaling me that this is not true. You want to detail medical problems because many of these conditions that I mentioned can cause mental symptoms. I find it very helpful to have the patients or their relatives bring in all the medications on the first visit. I forgot to do that this week, and now that we have fax machines, I was able to have them fax me a list. But it's much easier if you have them bring it in. It avoids some of the confusion of what they're taking. And often you'll see what has been termed the shopping bag effect, where literally a patient comes in with a shopping bag filled with all these different medicines. You can get an interesting history of the wonder drug of the decade, from Milltown in the 50s to Valium in the 60s and so forth. What often happens, a patient is on a medication, they do well, they change doctors, and the new doctor says, well, they're doing okay on this medicine, I'm going to leave them on that, and I'm going to add this other medicine. So sometimes just reducing the dosages of some of these medicines can have a tremendous impact on mental state. You want to rule out medical causes. Often a more extensive neuropsychological assessment can be helpful in differentiating depression from dementia. And then I find it very helpful to frame therapies in the patient's perspective. Now, this can be quite useful if you have a patient who has a mass depression, who doesn't really feel like they're depressed. If you say to this person, well, you know, it's not your back pain that is a problem, you're depressed. Well, that patient's going to get angry. They're going to feel that you've contradicted them and you don't take their symptoms seriously. On the other hand, if you say, Mr. Smith, you've been discouraged lately, you're not sleeping, you're losing weight, I have a medicine I'd like you to try for that. Now, it's called an antidepressant. I know you don't feel depressed, but I'd like you to try this. If you use that approach, the patient's much more likely to cooperate with the treatment. There are, I mentioned the extensive neuropsychological tests that can be done, but there are some bedside tests that are quite useful. How many of us here are familiar with the mini mental state examination? So this is a pretty sophisticated group, and that's pretty helpful as a broad screen for cognitive impairment. And you can even use that to follow a patient if you're treating them with an antidepressant to see if they're responding or the antidepressant may be causing cognitive impairment. There are other even simpler tests. For example, this is the SET test introduced by Isaacs and Kenny, which essentially is a wordless generation test. And you ask the patient to name up to 10 items in each of these 4 categories. And the perfect score is 40. I like it because all you have to remember are 4 things. And there's actually a mnemonic for this, and that's the word fact. You know, one day I'd like to reduce all of medicine to one word, but my fear is I'd forget that word and I have to go back to medical school. This is actually a figure from a book by Jeff Cummings and Frank Benson on clinical dementia, where they showed the copy figure test in a patient with Alzheimer's disease 1 year, 3 years, and 8 years into the illness. And I think it illustrates quite nicely how you can see visual spatial functioning decline over time. Here you can see the 3-dimensional figure begins to break down even in 1 year, and then it becomes more and more primitive. A very helpful test for visual spatial skills, and is actually a version of this is included in the mini mental state examination. Another test that is included in the mini mental state, and that's just the write a sentence or agraphia test. And here are some examples where here's someone that looks like they have some perseverative problem. I like. Here's someone who has poor penmanship but definitely likes crab meat. So this test will give you a crude indication of a person's language functioning. Before we talk about specific medications and medication strategies, I just wanted to review with you the age-related changes that will affect drug dosing. So we all know about the polypharmacy and the decreased renal and liver function, and how, unfortunately, fat-muscle ratios increase. And taken together, we generally use lower dosages for older patients, maybe a half to a third, but we don't know for each individual patient exactly what their best dosage is. And in fact, some older people need the full young adult dosage, so we tend to start low and go slow as a general strategy. And sometimes with medicines that are often prescribed once a day, if we prescribe them divided throughout the day, we can minimize some of the side effects. Here we have the psychochiropractor. I'm a little bit scared to show this slide. This is a tough crowd here. And how does that make you feel about your father? Okay. I was never going to bring another cartoon to a lecture after today. It makes the point that when you look at the studies of geriatric depression, that in fact, if medication is indicated, a combination of psychotherapy and medication therapy is more effective than either alone. And what I mean by psychotherapy is not necessarily in-depth, insight-oriented psychoanalysis, but it can be very simple education. It can be just spending a few minutes with the patient to find out what's going on. This can go a long way. Now, just to give us a time perspective on antidepressant treatment, it really wasn't until the 1930s when we had the first safe, effective antidepressant treatment, that's electroconvulsive therapy, or ECT. In the 1950s, the first generation of medication treatment, TCAs or tricyclic antidepressants, were introduced, and the MAO inhibitors were introduced. And then in the 80s, we saw the selective serotonin reuptake inhibitors, which have replaced the TCAs or tricyclics as the first treatment for depression. And then now we have even newer medicines. I didn't bring slides on all of them, but I'll try to mention a few in passing. Let me just say that for depression treatment, basically all these forms of treatment are effective. Maybe, I don't know about black bile, I don't endorse that, but perhaps after this break, these are all equally effective. ECT is certainly the most effective for serious depressions if someone is psychotic and depressed. But in general, the SSRIs and newer medicines like nifazodone, the MAO inhibitors and tricyclics are equally effective. The differences are in the side effect profiles, and that's really where the importance of choosing a medication comes in. If we look at the tricyclics, we can see that there are several advantages and disadvantages, particularly when we're talking about medically ill elderly patients and patients with comorbidity. Advantage, proven efficacy. They may be more effective. I wouldn't necessarily say psychotic depressions, but for the severe melancholic depressions, there's some perhaps controversial evidence that they may be more effective. You can get valid blood levels on some of them, and the cost is low because they've been around, but I'll get back to cost in just a moment. Disadvantages are basically all these side effects: sedation, cardiovascular effects. You get a lot of autonomic side effects, postural hypotension. If you have an elderly woman with osteoporosis, you don't want her to get up suddenly if she's taking a tricyclic because she could fall and fracture a hip. Or an elderly man with prostatic hypertrophy. That anticholinergic effect could lead to a complete shutdown of his prostate. And then they're lethal in overdoses. But still, in some situations, we do use them in elderly people, and reasonable drugs might be nortriptyline or dizipramine, which seem to have lower side effect profiles. Well, let me just, before I get on to this, let me mention one other problem, and that is that these tricyclics have an antiarrhythmic effect like quinidine, and there's a recent study indicating that patients who have had heart attacks and have ventricular irritability following the heart attack, that if they take a quinidine-like drug, that they're at increased risk for death. Now, this was the cover of Newsweek in March of 1990. I think Prozac had been introduced about a year and a half earlier, and when it was introduced, there were about 24 antidepressants on the market. What percentage of the market share do you think Prozac took over? Anybody? 60%, 50%? Actually, it's a little higher, 70%. So, as I said, Prozac is not any more efficacious than the other antidepressants, but it definitely had a better side effect profile. And 4 years later, we see beyond Prozac. I predict next year we're going to have son of Prozac. If you look at the three generally used SSRIs, or selective serotonin reuptake inhibitors, you see that they differ in terms of half-life. I'll point to the generic name and mention the trade name. So this is Paxil, Prozac, and Zoloft. Prozac tends to have a longer half-life than the others. The dosing is a little different. And side effects are relatively similar. You tend to see a lot of GI complaints. That's the most frequent complaint, and some people complain of headaches. A lot of our elderly patients may get activated as a result of it, and that might be a situation where you want to choose an alternative. And examples of alternatives might be a new drug that just came out, nifazodone, which tends to be sedating, doesn't have a lot of anticholinergic effects, and other autonomic side effects, and is well tolerated. Another indication for it might be, and we don't see this that often in our elderly patients, but we do see it, the SSRIs can cause sexual side effects that are troublesome, and newer drugs like nifazodone don't do that. Another alternative that people are using is trazodone, which also is sedating, but does have some of the unwanted side effects that I mentioned, in addition to very rarely priapism, which often makes men reluctant to take it. The MAO inhibitors have the theoretical advantage that MAOI levels increase with aging, They have low direct cardiac effects and may be more effective for these atypical depressions where people have a lot of anxiety and increased appetite. But you have to follow these dietary restrictions or else a patient can develop hypertensive crisis. More commonly, what we see in older people is that they get postural hypotension on MAO inhibitors, and that can limit their usefulness. Here's a list of some of the foods that have to be restricted if somebody's on an MAO inhibitor. So you have aged cheeses, red wines, especially Chianti, sherry, vermouth. Now, you show a list like this to some patients and they get more depressed. If the patient happens to be obsessive compulsive, they like it. It gives them a way to bind their anxiety. Please note that meperidine can have a potentially fatal interaction with an MAO inhibitor, so I recommend that people wear medical alert bracelets if they're taking an MAO inhibitor. There is this overlap of Alzheimer's disease and other dementias with depression. And if you're going to treat a patient who is demented and depressed, please avoid a tricyclic antidepressant because of the anticholinergic effects. This would be a place for some of the newer compounds that don't have these anticholinergic effects. We know that Alzheimer's disease patients have a deficit in their cholinergic systems, and we don't want to aggravate that. In addition, a lot of our patients with Alzheimer's disease are taking drugs to enhance their cholinergic neurotransmitters. And so they may be on Cognex or Tacrin, which is a cholinesterase inhibitor. You wouldn't want to give a cholinesterase inhibitor and an anticholinergic drug at the same time. We hear a lot about drug-drug interactions, and I know that Jaime Fitton will be focusing on them in more detail. I just wanted to mention the P450 interactions because the SSRIs and a lot of the newer antidepressant compounds will cause interactions, and medicines to think about include many commonly used antihistamines and other drugs. Now, benzodiazepines are often used to treat people with agitation, with insomnia, and a variety of other complaints. When they're used, you have to be cautious to avoid some of the long-acting compounds. And here you see this quite graphically, a study comparing young patients with older ones. The young ones are in orange and the older ones in blue, and this is the elimination half-life in the body. With diazepam or Valium, you can see the older patients have a much prolonged elimination half-life, up to 75 hours compared to about 30 hours, and it can go up to several weeks, versus the newer compounds like lorazepam and temazepam. You don't see that effect. So typically what happens, you start the patient on the drug, they do better, but then they begin to get ataxia, sedation, cognitive impairment, and the like. Another common practice is that a physician may want to treat a patient's anxiety or insomnia with an antihistamine, thinking, well, this is a safe drug. It's not going to really cause problems, but it's really not the drug of choice if you have those kinds of symptoms, primarily because they have anticholinergic effects that can cause confusion and constipation. For patients who are agitated and demented, for many patients with delirium, and for patients with psychotic depression, we will often use an antipsychotic or neuroleptic drug. And similar strategies of choosing a medication according to side effect profile are in order. So if we look at some common examples, Haldol would be an example of a high potency medication. So 1 or 2 milligrams of Haldol is equivalent to a low potency agent milligram dosing, say Thorazine of about 100 milligrams. Haldol has greater effects on extrapyramidal systems so that patients get Parkinsonian-like side effects, rigidity and drooling. Thorazine is more likely to cause sedation, anticholinergic effects, and postural hypotension. For an intermediate compound, a novel neuroleptic, risperidone, is often chosen, and particularly patients who have a lot of sensitivity to extrapyramidal effects sometimes will use clozapine, although there's a risk of shutting down the bone marrow, and so you have to follow the patient's blood counts relatively closely. Now, a moment ago I mentioned an advantage of tricyclic antidepressants is low cost. And in this day and age, when we're concerned about healthcare costs, we're scrutinizing our formularies and thinking very carefully about drug unit costs. And here's an example of a pharmacoeconomic study which indicates that if we just look at the cost of the drug itself, we're being short-sighted. If you look at the direct cost of drug, you compare, in this study they compared a tricyclic versus an SSRI, you find that the relative cost for the tricyclic is about 11 versus 23 for the SSRI, so it's about twice the initial cost. However, if you factor in broader costs, ICU visits as a result of adverse reactions from the tricyclics, physician consultations, hospital stay, and that would be included in the, here would be hospital costs and physician costs. You find that tricyclics are actually more expensive than the newer SSRIs. So hopefully we'll be accumulating more and more data that will help guide us rationally in choosing what medications we use. Estrogen also has made the cover of our national news magazines, and it may be the wonder hormone of the decade, and certainly the grants I've been reading, it's almost every other one seems to have estrogen in it. There's a lot of interest in its effect on mental functioning, not only in terms of enhancing cognitive ability, but also in terms of enhancing depression. An example is a study that I did with Lon Schneider over at USC, where we looked at women who had taken an antidepressant versus a placebo and assessed whether they were on estrogen during the study trial or not. And we found that women who were taking estrogen plus the antidepressant got less depressed. They actually improved more than women who were on the antidepressant alone. And a similar kind of analysis was recently done in a study looking at Tacrin in patients with dementia. And there's other evidence suggesting that estrogen may prevent the development of dementia. So we've got a lot of trials that are ongoing and other epidemiological studies that will give us more information in the near future. This will be my last visit, doctor. I found a bartender who's cheaper. Okay. Whether it's a bartender or a psychiatrist or a family practitioner, it's clear, as I've emphasized, that talking therapies are important. Here's a study that demonstrates that. It was done by Bert Reifler and colleagues up at the University of Washington, and let me just explain this to you. These were patients who had Alzheimer's disease and depression, and the vertical axis shows degree of depression, and the horizontal axis is the number of weeks in the study. And they find with the antidepressant, represented by the orange, people did very well. But they also did very well with this drug, represented by blue, known as placebo. Very effective antidepressant. So clearly, just having the caregivers bring the patients in, talking to the investigators and physicians had an impact. I have a theological question. When you die and go to heaven, are you graded on a percentage or a curve? On a curve naturally? How can you be so sure? I'm always sure about things that are a matter of opinion. So with that last slide, maybe we can have the lights and we have a few minutes for questions where I can offer even further opinions. Thank you very much for your attention. No opinions even on the cartoons? Okay, then thank you again. Oh, here's one, yeah. Fact, yes. She's testing my memory, you know, there's... Okay, so fact, fruits, A is animals, let's see, T is town, so C is colors. Thank you very much. Okay. Okay. Oh, yeah. That was. Thanks for bringing that up. That was actually all ages. We really don't have the data yet for older adults, but I think we'll be seeing that. It's a burgeoning field, subspecialty. Yeah.
Is there good evidence that very low doses of tricyclics for depression? I saw your dose range 10 milligrams up to...
Question: is there good evidence that low doses of antidepressants are effective? in older people. There's at least one study I know where they used doxepin in doses of about 20 milligrams, and I can tell you just from my own clinical experience, I've seen pharmacologic effects from 10 to 20 milligrams, no question about it. Yeah.
Can you talk about the different uses of anti-anxiety agents when you use benzodiazepines versus buspirone?
Yeah, thank you. The question of benzodiazepines versus buspirone, I appreciate that because I didn't have a slide for buspirone just because of time. Buspirone is another anxiolytic that has some advantages over the benzodiazepines in that it doesn't have these effects on ataxia and sedation and so forth. It takes about 10 days to 2 weeks for it to have an effect. One problem we tend to see with it is that a lot of times a patient will be on a benzodiazepine. You want to get them off the benzodiazepine and onto Buspar, and the doctor will detox the benzo at the same time that they add the Buspar, and it doesn't really work that way. I recommend that people get them on the Buspar and then detox the benzo. Yeah.
When you're assessing psychiatric disturbances in older patients, what instruments do you like to use?
Assessment of psychiatric disturbances in older people, what instruments, the primary instrument is a good mental status examination, really to cover all the bases that you need to cover. In terms of rating instruments that I personally use, I like to use the Hamilton Depression Scale, and I like to use the Mini Mental State Exam, and sometimes the Blessed Dementia Score, just as a first pass, because I've used them a lot, and I know how they compare with other patients I've seen. But there are a lot of different scales out there that have various advantages and disadvantages, particularly if you're in a busy primary care practice. You may want to consider self-rating scales. There's a lot of self-rating scales for depression that you can give the patient in the waiting area, and that can kind of alert you to whether you need to focus on depression more. Okay. Yeah. The question is depression in caregivers. There are several studies, and what they generally find is that remarkably up to 50% of primary caregivers for demented patients themselves get depressed. And that's not just minor depression, but major depression. So I think that one could say that's a major risk factor for depression, and to keep in mind when you're seeing families. Okay, thanks again for your attention.